Welcome to the Doctors Making a Difference podcast, where we help physicians to be empowered with the tools they need to be successful in medicine, in finance, and in life. Join us as we highlight doctors and other professionals around the world who are making a difference. Hey, everyone. So today we're going to hear an interesting interview with Dr. Sanjeev Kumar. He introduced himself here in a minute on the podcast, but I wanted to give just a little bit of a preview. Dr. Kumar is a really interesting surgeon. He's been on the forefront of gynecologic, oncologic surgery and has been on the leading edge of robotic surgery. There's so many things you can do with that technology. It's very interesting to hear his passion. And he talks about artificial intelligence and how that affects it. I got to say that I hear this question quite a bit from my kids and people of that generation, medical students. What's going to happen with AI? Am I going to be replaced as a doctor? Do I still have relevance in this field? I think there's a lot to be said by having a physician, to have the wisdom and the knowledge and the judgment of someone that understands this field. Large language models, what we call artificial intelligence, have access to tremendous sets of data. Every book in the world, every published study, everything that you can imagine on that. And some of them are a little more discriminatory about getting good peer-supported data, and others just pull everything from Reddit to everything that's online. So sometimes they pull out information that's not useful. But there is a place for AI. Think about if you have a decision helping tool and it has every study in the world at your fingertips, or you have something in the surgical field, the robotic surgery, and every surgery ever done, every complication ever documented is right there at your fingertips so that you can understand what comes next. Instead of being fearful of AI, we can be hopeful and say, this is something that's a tool in our hands. By no means is it a replacement for having a physician, but it is certainly a helpful tool, and we need to help craft that. So I think you'll enjoy this interview with Dr. Kumar. One of the purposes of this podcast is try to leave medicine better than we found it. And I think you'll find him to be a delightful guest, very interesting, very engaging, has lots of stories. So I hope you'll enjoy it. Thank you. Okay. Today, I'm delighted to welcome Dr. Sanjeev Kumar. Dr. Kumar is a gynec surgeon, an accomplished surgeon who works a lot with robotics. I'm very excited to meet him and talk a little bit about what he is doing. Dr. Kumar, would you mind introducing yourself to our audience?
Yes, hey there. My name is Dr. Sanjeev Kumar. I'm a double board certified G1 oncologist, board certified in OBGYN as well as gynecologic oncology. And I have a special interest in robotics. I've done a lot of robotic surgery, very passionate about it, past, present, future. And I see great future in robotic surgery in helping the patients. And especially in the age of AI, the AI has been introduced into robotics. And so where it is evolving is quite fascinating.
Yeah, I'm really excited to get into this. Just as a little background, briefly tell us your story. I know you mentioned you were born in India. You did some work in the United Kingdom. You work in the United States now, but talk us through that. It's difficult to operate in and do something complex in a culture that was not where you grew up. And then you chose surgery. How did you choose this path?
Yeah, it's a great question. So I grew up in a farming family back home in India. And right from the childhood, I had a dream that it'll be very, very nice to work with my hands. I thought I was always good with my hands and had good skill and always wanted to help people. And I thought that it's a great idea to become a surgeon where your hand-eye coordination, your manual skills come into play. So I thought that it'll be a great idea to become a physician and a surgeon and to develop a skill in a kind of like a niche field. So I was always a big fan. When I was growing up, actually, a close friend had an uncle who was an interventional cardiologist and was in practice in the UK. And he used to tell me stories how patients will fly from faraway places to seek care with him because of his skill. And then I graduated from med school in India from a city called Chandigarh, which is in the North India. And then I went to England and had an opportunity to actually work with a pediatric surgical urologist in England. And the same concept is that he specialized in doing very, very niche procedures where pretty much he and three or four other guys were doing complex like developmental anomalies in kids, like hypospadias and
Hmm.
things of that nature. So kids will fly over from all over the country and will do fairly complex operations. So that's where I saw that you gotta develop a niche practice, a skill that you can push the field, push the envelope, and take the field forward. And then along the same thread, when I was doing fellowship at Mayo Clinic, Rochester, Minnesota, in GYN oncology, my mentor, Dr. Bill Claby, we were talking one day. And so I was like, fellowship is going well, this and that. But then how do you develop a career? We were having breakfast one day in the hospital cafeteria. And he's great at, making it funny and he teaches by stories. So he goes, well, Sanjeev, he said, try to find something that nobody else is doing and get good at it.
Hmm.
And that's a great way to develop a career. I'm like, that's awesome.
That is awesome.
Yes. So that's kind of how I always looked at things is that how can I focus in an area and then go real deep into it and then develop it. And so going back, how I chose a surgical branch, basically, at least that's how I look at it, is that no illness is easy on people or the patient. But as they say in The Emperor of All Melodies, I don't know whether you've read that book or not, but if you haven't, it's highly recommended. Written by Dr. Banerjee, Emperor of All Melodies,
Hmm.
basically says that cancer is the king of all illness. It's kind of like a form of life. It has its own life. It evolves. But I thought that to treat cancer is the most challenging aspect of medicine. And then I was interested in surgery, so I kind of mixed it. And hence, the areas that were fascinating to me were where I would get a chance to do cancer surgery. And so there were two ways to get there with the exposure that I had. Either you become a surgical oncologist or you become a gynecologic oncologist. And when I calculated the number of years it takes, surgery residency is 5 years and OBGYN residency is 4 years. So that's how I ended up where I ended up. Med school in India and then did fairly broad based surgical training in the UK. And then I came to the US where I did OBGYN residency at Wayne State University and then a GYN oncology fellowship at the Mayo Clinic, Rochester, Minnesota. So that's kind of how my path came
Oh,
about.
thank you for sharing. Like you said, even from a young man, you knew you wanted to work with your hands. You wanted to make a difference. You wanted to help people. And then you got some excellent advice from your mentor. Do something that is unique that nobody else is doing, dive deep and get good at it. And so it sounds
Yeah.
like you came into this and had this experience and then found that the robotic surgery was something you could really excel at. And so, most of the listeners of this podcast are doctors. They're going to be familiar with robotic surgery and the concept of what happens. But maybe just outline a little bit for those who don't know quite as much. A robotic surgery, some of my patients think, does that mean a robot's doing my surgery? No, it's the surgeon, but the tools and the controls are not necessarily on the patient's abdomen or at their pelvis. They're sitting a few feet away. And so it's a change. And I wanted to kind of hear your perspective on that as you went from classic training to robotic surgery and now a person who's really leading in the field of robotic surgery and gynonc. How has that affected your surgical capability and also what kind of cases can you take on that maybe you couldn't have taken on with the previous techniques?
Yeah, it's a great question. It's a fascinating field. And the reason why I got into it, again, using the same theme of trying to develop a niche practice. So when I got into residency, robotics was in its infancy. At Wayne State, as an OBGYN resident, they had just gotten their first Da Vinci around that time when we were junior residents. And that was a time, I'm talking about 2006. is that senior physicians were still training their junior partners. And I don't know what version, I guess it was Da Vinci S version that had come out. It was very clunky, big. And by the way, the question you asked that, hey, my patients think that the robot will be doing the surgery. A lot of my patients will ask me exactly that question, actually, that, oh, Dr. Kumar, does it mean that robot will be operating on me and it will not be you? And so I used to actually take all my time to explain that, hey, even though it is called robotic surgery, I'm still controlling the machine. Although the machine does the operation, but I'm the master of the machine. And I'll tell you a funny story. One day a patient came in and she said, I want to see this thing that is going to operate on me. And obviously the Da Vinci is always parked in the operating room.
Right.
So I said, I'm like a huge fan of patient focused care and great transparency and things like that. So I was like, okay, I mean, we're talking about 7 a.m. Surgery start is 7:30. So I said, well, if you are that insistent on looking at the robot, let's go walk in the operating room. And so she's in her gown and we are walking. I'm in scrubs and, my white coat, and we are walking towards the OR. And all the nurses are like, what's happening? We've never given a patient the tour immediately before surgery. I'm like, guys, it's a great idea if you let the patient tour and actually see. And I think a lot of the hospitals now have like a replica of the robot in a lobby or someplace like that. So where patients and community members can actually see what this thing is all about. But it's amazing tool. Coming back to what type of edge it provides, right? So I can talk about two very specific areas. So let's say you have a tumor in the retroperitoneum, but very deep in the pelvis, let's say in the hollow of the sacrum, right?
Hmm.
So like sacrum is like this, and the tumor is sitting right in the hollow. If you are trying to do open surgery on a patient, that's very challenging because the tools, they're not bent like that. Either you have straight
They
tool.
don't match the shape of the sacrum. And there's so many structures between the anterior access point and the back of the sacrum. You're right. That would be very challenging.
Exactly. Also, everybody's pelvis shape is actually different. Some people have a very narrow, long, and funnel type of a pelvis. Others have a little bit of a broader pelvis. So, manual access to these tumors becomes very challenging. And you realize that if it's a large tumor that is growing in, let's say, sacral foramina, in all the spaces of the pelvis, wrapping around all the nerves, it becomes very, very difficult with the naked eye, even if you have magnifying glasses, to actually see it. Now, robotically, your vision is magnified multiple times. So let's say routine magnification, let's say is 6 times. Sometimes it can be even 10 times. So you can actually just see so much better. Like even the very, very small blood vessels, they pop at you. And so you're able to navigate and do those type of surgeries in a much better fashion. There's an operation I can tell you about. It's called radical nerve sparing robotic trachelectomy.
Okay.
So in this particular operation, let's say if somebody has cervix cancer, right? Cervix cancer is notorious for spreading in the parametria, which is the tissue surrounding the cervix. And it often will go and trap the nerves of the pelvis. So in the traditional approach where you clamp, cut, open surgery, you end up damaging a lot of nerves. So traditionally, if you get a radical trachelectomy for cervix cancer, you can have a lot of bladder dysfunction and sexual dysfunction after that operation. So take a corresponding operation in men. So somebody has prostatic cancer. It's very common. I mean, if you live long enough, every man is going to develop
Right.
prostate cancer,
Correct.
right?
Hmm.
And if you undergo an open prostatectomy, a lot of men develop impotence, erectile dysfunction, After that, it's because the nerves have been damaged. They will require catheterization because the bladder doesn't function because it's basically denerved. And a lot of times they can develop defecatory dysfunction as well, where stool will not pass. Robotically, since you can see everything much more magnified, and it's 3D vision, it's not 2D vision. It's three-dimensional vision where you actually feel as if you live in that pelvis. You can actually see all around. Imagine watching like a 3D movie and the anatomy is magnified 6 to 10 times. So you can actually trace those nerves and preserve them. So in this operation, robotic nerve sparing radical trachelectomy, you can actually save these nerves, and the post-operative bladder dysfunction, sexual dysfunction is much less or negligible. So like in the past, after doing open operation, we will be sending the patient home with a bladder catheter. But after the robotic nerve sparing radical trachelectomy, patients can actually pass urine just fine and they will not require catheterization and not develop bladder infections and things of that nature. Sexual function is much better. So it's day and night. And then in terms of specifically benefits of robotics, second main area is operating in obese patients. So after specializing in robotics, I realized a lot of people started sending me patients that are at extreme body weight. And I'm talking about body weight of 400 pounds, 500 pounds, body mass index 70,
Hmm.
60. Since obesity is the main cause of uterine cancer, endometrial cancer, that's the number one cancer that we as GYN oncologists treat. So I started getting a lot of very, very obese patients. And in that particular patient population, the benefits of robotics is like magnified because you're using keyhole surgery, very tiny little incisions. These patients can go home the same day. Infection rate is minimal. So imagine the wound infection rates if you're doing like open surgery. It is said that if the BMI of the patient is, let's say, in the range of 45 to 50 to 60, after open surgery, the wound infection rate is about one third. 30% of the patients develop wound infection. After robotics, it's minimal, maybe 1 or 2%. So drastically different. And so this segment of patient population is the greatest beneficiary of robotics. And then you talk about rare things like if a cancer is wrapping around the blood vessel, now you can peel it off robotically because you can just see much more. And many times you will not need to resect or put a graft on. So more cancers have become resectable, which previously could not be resected. So just tremendous advantage. And if you look at future, increasingly people are discussing cutting edge concepts like telesurgery. If you go historically, robotic surgery actually developed with the initial funding from the Department of Defense. And robots were initially conceptualized that you could operate in space or you could operate in the battlefield from the carriers
Mhm.
or even mainland. So that was the original application of this technology. But it kept sitting on the shelves with the Department of Defense and Pentagon. And then when the technology broke out, then the commercial players started developing it and it found its application initially in fields like urology, gynecology. And people would ask that, hey, why urology and gynecology first? And the underlying fundamental is that robotics fits well when you're operating in a localized field. So let's say if you have ovarian cancer, right? Ovarian cancer is widely spread in the abdomen. You can have tumor nodules in the right upper quadrant, left lower quadrant, all the four quadrants of the abdomen. So that's not an ideal tumor for the robot to remove, although it has its applications there as well. but because the tumor is widespread, the application is less. Whereas if you're operating in a focal regional area, like let's say prostate operation, you're right there, you're not moving in different quadrants of the abdomen, and similarly hysterectomies. And therefore, this technology developed in those fields first, and now it is expanding. And so telesurgery is now coming up. There's a company that I personally know out of India that has performed many, many telesurgeries. It is finding its application in heart surgery, gallbladder surgery, things of that nature. So things are, moving forward with an exciting pace, actually.
We were talking before we hit record about the important work being done in other countries. I've had a chance to do volunteer work in parts of Africa with very limited medical resources. And it's a developing technology, but the ability to bring some of these things to underserved communities is pretty neat. And it's still something that we need to work the kinks out, but it sounds like it's already being done in real time. It's interesting, like you said, that it had a background with the Department of Defense because there's a lot of need for remote surgery. But the thing that I've also found interesting, not in the world of gyn onc, but even in our small communities, like I work in a rural area, even the small hospitals in my region, almost every hospital has a Da Vinci because that's become the standard for urologic surgeries and routine gynecologic surgeries. As you said, there's been a tremendous advancement in that field, and it's pretty amazing to watch. Where do you see it going over the next few years? Like, obviously, it's been sort of this moving target. You've been in it for several years, and I'll bet it changes rapidly. But I'm curious, where do you see this going in the era of artificial intelligence and large language models as we go forward in over the next 5 to 10, 15 years?
Yeah, that's a very, very important question. And so let me go back to where the field is going. So Da Vinci is from Intuitive Surgical and pretty much has had monopoly on the market. I mean, you have other surgical robots. Don't get me wrong. You have like Mako system. Mako is used for knee replacements in orthopedics. But Da Vinci is probably the most complex robotic system and is the most advanced robotic system. And as they call it, the true robot, meaning that it has, let's say, 4 arms. So traditionally, when I'm doing surgery, I only have 2 arms and I need good assistance, right? But this alone has 4 arms, so I can actually control way more than I can do with my hands. But now, a lot of other companies are actually manufacturing the equipment because a lot of the patents that were developed by Intuitive Surgical, the embargo on that has gone away. So the market is becoming more and more open. And few companies have applied for FDA approvals, even in the US market. I personally know that SSI Innovations, for example, it's a new company developed by a heart surgeon out of India that has applied to be in the US markets. And they're going through the FDA evaluations right now. But as more and more devices come in the market, I think you'll have a rapidly developing technology. And the monopolies, as you see in the past, not real good for development, right? Anytime you have a monopoly, the developmental rate is a little bit lower than what it can be if there are many, many other competitors competing and improving the technology at a faster rate. So now that is starting to happen. What I foresee is, as compared to just the Da Vinci alone, I think more and more models will come into the market and the cost will decrease. The accessibility will increase because, believe it or not, although pretty much every hospital in the US has a machine, robotic machine now, I mean, the main hospital
Right.
systems. But even then, the staff training is not as good. So, for example, in the market where I would do my operations, you could see that you have a robotic crew. So, people that are well trained on the machine, all the parts, how to dock it, how to troubleshoot. And they are on a shift from, let's say, 6 to 3. So you did your 3, 4 operations, then they go home, and then it becomes a nightmare. So if your list lasts beyond 3:30, the robotic crew is gone. Now you have somebody in the OR that they'll say, "Doc, I have no idea. I mean, how
You know,
to,
they haven't used it. They haven't worked with it day by day like the robotic crew.
Yes. And so that limits the accessibility. So I've seen some surgeons, they could do 4 or 5 surgeries, but since the accessibility is so limited, they will only do 3. So with the cost declining and more other devices coming in the market, I think the accessibility will improve, and that'll be greatly beneficial for the patients. And I think the ultimate thing will be to have remote surgery where you can have an expert surgeon that could apply their skills to even remote locations. Also, traditional areas where, let's say, heart surgery or even spine surgery, where robotic applications were at a lower level, are now coming into the picture as the instruments are improving as well. So it's rapidly evolving.
You know, a question that I get pretty often, primarily from students, high school students, medical students. The question is, okay, AI is going to take my job. Our artificial intelligence, large language models are going to modify how I do it. I think there will always be a need for a physician. I don't ever see a time where you're going to put all your care under the direction of some, large language models just connect sentences and phrases, and they may have all the data in the world, but you still have some judgment and wisdom that has to come from someone that does this and can actually think. And so I'm interested in how you see AI affecting the field of robotic surgery and telesurgery and all those things. And then also, how does this affect the choices of those who are rising medical students, pre med students, residents, as they contemplate what's the potential effect of AI on the field of surgery from your standpoint?
Yeah, it's a great question. So I was watching a YouTube short one day, and it was Elon Musk speaking to a reporter. And I think you might have watched it. He's saying something like, within 3 years, the Optimus will be able to perform surgeries that'll be much more precise than any human surgeon alive within 3 years. And that's a fascinating and very, very interesting comment. I don't believe that right now because there's just so much judgment involved in surgery, and every patient is just so different. But still, technology is improving at a very, very rapid rate. I don't think that physicians are going away anytime soon. So I don't think the medical students have anything to worry about. But they should understand this, that the kind of things that they will be applying their judgment, the problems will be different. Because, so let's say our days, like mine and your days, when we were reading, probably, I was learning a lot from Up to Date, for example. And even before that, when I was in India, let's say in med school, I'm talking about 1998, 1999, textbooks were the main thing.
Mm-hmm.
I kid you not, if I could see a 3D picture, I would be like, whoa, that just made the anatomy learning so much easier.
Mm.
And now you can actually build these anatomy images on Grok, like with, a few buttons. So learning has become so much easier, right? But then it has shifted the pendulum of what you actually need to learn. So now the learning probably is, hey, what is actually the best AI model that can be applied to cancer surgery learning? Because we have covered so much ground already. What is the next frontier? So as these models keep evolving, I think the the spectrum will change. As somebody said, the only job that is never going to go away is the job of solving a problem. So what kind of problem you solve will be different. So now let's say we can ask Chat GPT, I got this type 2 hypertensive or type 2 diabetic. what's the standard of care, and it will rattle off few things. Sometimes it'll be wrong. That's why I cannot, rely on it. But by and large, it'll give you like generalized medical knowledge. Every year it will become better and better, but then every year the nature of problems will be different as well. And so that's why I think learning how to learn is not going to go away. So I think current medical students, they need to have an open mind and they need to embrace this technology and master it rather than being scared of it. So I think, at least in my view, no, doctors are not going to go away. Problems will still remain, but the nature of them will change. I think you'll probably pretty soon have fellowships specializing into just robotic surgery, for example, or AI generated robotic surgery. Now, let me see what I have seen so far, how AI is integrated into robotics. So the robotic systems now, they track literally every movement a surgeon makes. The robotic platform connected with the computer, and every surgeon that is using that system, their data is fed into it. So let's say we talk about hysterectomy. The companies now, they have data on at what step surgeons are taking the longest amount of time. Is it at the right uterine clamping or left uterine clamping? Or is it coming at the vaginal cuff coring? Or it is dissection of the right IP ligament or left IP ligament? And now they are able to build models that, okay, we see maximum amount of bleeding at the time of right uterine cauterization. So that's the area where we need to teach more, and that's the area that needs to come into focus. Things like, okay, at the time of dissection of the right ureter, people are getting into most trouble. So those kind of hardcore data models are now being developed because with literally thousands and thousands of operations being done daily, these machines are learning that. It's no different than, let's say Google Maps, and you started using Google Maps, and Google has now information that, okay, XYZ left turn has the maximum fatality rate, right? So those type of things are being fed into these systems, which, if you can imagine what we can build on top of that data, will be pretty fascinating. Imagine going into an operation where the moment you put your head down, you already see that, okay, in this operation, these are the critical points. Right uterine, be careful when you're in that area. Right ureter, and then left IP ligament. That's where we see most surgeons spend most of the time and most of the bleeding. And then going one step further, then since all of these movements are recorded, trying to develop models of if you run into this problem, how do you resolve it? So let's say there's an anatomic variation. Let's say somebody's uterine vein is coming in front of the ureter, behind the ureter, and that's developmental anomaly, right? Traditional anatomy teaching has been on traditional atlases. Now, I kid you not, robotic anatomy is completely different because you can actually see way more. You could see vessels that you had no idea existed because the thing is magnified. So that's where the AI is helping in developing these tools.
Great answer. And I think when I answer people on these questions, just like you did, I think it's better to go forward with hope and say, I'm not worried about replacement. I'm excited about what this can help us do. Instead of saying, I need to go look that up, the information, the data will be immediately available. And if you're an expert in the field and you already know it, that information is very powerful in your hands. Very similar to what you just described. If you have that information about the variants of anatomy, hot spots or trouble spots on the surgery, suddenly instead of being worried about AI, you're thankful for the AI to say, how could this help me navigate this complex problem so that this patient gets the very, very best outcome? And
Yeah.
anyway, I love your perspective. I appreciate it. As we get a little closer to our time finishing, I wanted to just ask you if you have some resources or a website, or how can people follow your work? Because I think this is very important. And obviously, you've had a tremendous role in developing this field. And it'll be very interesting to watch over the next several years as other surgeons come into this and develop this process, where we can take it.
Yeah, no, absolutely. So I'll give you another example that nowadays, if you see a person using a flip phone, you'll be surprised, right? You'll be like, hey, where's the touch screen right here?
Hmm.
Robotics and AI are no different, is that it's better to inculcate the technology, learn it, so we don't get left behind. Because every year, the pace of learning the technology and technological evolution is actually increasing. The speed is increasing. So either embrace it or get left behind. And you definitely don't want to get left behind.
No.
So you want to stay ahead. And people can follow me on my LinkedIn, which is probably the best. And then I have my website. We'll post the link as well.
Okay,
And
perfect.
any questions, I'll be happy to take them by email or even phone. And I will be happy to discuss any questions, any issues, things of that nature.
Hey, Dr. Kumar, I really appreciate it. I think it's fascinating, both from a technological standpoint, but I love your perspective on helping patients, using your skills to develop a niche skill set that you can really help folks. And that started out just like you did from the very beginning. I want to help people, and I want to use a skill set that I can really develop deeply so that I can help people. And that's what you're doing. So thank you for what you're doing. I said the podcast is called Doctors Making a Difference. You're one of the doctors making a difference, and you are leaving medicine better than you found it. It's really cool. And I want to express appreciation, gratitude for what you're doing. So thank you.
Yes, no, thank you so much for the opportunity and the time. It's exciting time with evolving technology. And I wish everybody good luck in learning and applying it.
Thank you so much. Thanks for tuning into the Doctors Making a Difference podcast. And thank you for what you do to help your patients and your community. Your work truly helps so many people. We produce this content to help you have the tools you need to stay in medicine and to highlight the amazing work being done by physicians around the world. Please note that while I am a physician, and many of the guests on this program are also physicians or other professionals, the discussions on this podcast do not represent my employer or any professional organizations to which I belong. This podcast is for your information and entertainment only, and should not be taken as professional advice. You should seek appropriate professional advice pertaining to your own situation. Please check out more of our content on our website, doctorsmakingadifference.com. Also, please follow, like, or subscribe on your podcast player or YouTube channel, and give us a 5-star rating. It really helps to spread the message. Finally, if you'd like to be a guest on the podcast, or if you'd like to nominate someone else to be a guest, please visit the website or email admin@doctorsmakingadifference.com. See you next time.